Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humour and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
I'm Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
Today we're talking about vasomotor symptoms, what they are, why they happen, and why we really need to treat them.
Yes, we're going to really hone in on, just talking about like where they're coming from, but the big takeaway from today's, podcast is just to understand that they are not without detriment. I mean, we keep saying this over and over again. And we've been talking to us girls all week about just, we really need to hone in on how important it is to treat them, because every time you have one, something is happening to your body that is not good,
Right. And, 80% of women will have vasomotor symptoms, whether it's a hot flash or a night sweat, and they can be mild, moderate, or severe. The one thing that I've really have been, finding that I have really needed to ask a lot more clarifying questions with patients is about having hot flashes at night. Because I think because of media and TV, women don't think they're having any temperature elevations at night if they don't wake up sweating. And so I find that with women who are waking up with having frequent sleep awakenings, I'll say, are you waking up and you're noticing that the covers are on or off, or that you're kicking your feet out? And inevitably they say yes. I'm like, okay, that's a hot flash at night. Like, I wish we would change the nomenclature, because a lot of women don't think they're having hot flashes at night because they're not night sweats.
I think a lot of women, right. I don't think that they're having, I think if they don't think that they're having this big flash and taking their clothes off, that they're completely, thinking that they're not having any hot flashes at all. And we've talked multiple times that, that these changes in the ability to stand temperature changes, or you're running hotter and having to wear tank tops, but that you're not actually breaking out in a sweat necessarily. And I think for any practitioners that listen to us, you have to ask those questions, because they'll tell you, oh, I don't get a flash, I'm just a little warmer. Okay, that counts, honey. That counts. And so I think for our practitioners out there that are listeners, you need to ask those questions. Don't hey, any hot flashes, night sweats? No. Okay, let's move on. You can't do that. You're going to miss a majority of these women.
For me, my chest and neck would go bright red and my ears would be burning red, and I could feel okay, and other times I would have a full on hot flash. So these temperature fluctuations can be really sneaky.
I remember in clinic, doing breast exams on women, and literally the heat was radiating, like burning my hand. Like, I'm not kidding. And I'd say to the patient, do you feel that? And they're like, feel what? I'm like, that is a hot flash, my friend. You're burning my hand. Your skin is so warm to the touch. And Yeah, I just think that,
Hmm.
women, I think that we just need to talk more about it. And the other thing is that it's like, women will be like, it's not that bad. And I
Yes.
think I used to say, life's too short to have a period. Now, the more that I've learned about the damage of hot flashes, now my
Hmm.
new mantra
It's
is life's too short even for one hot flash. We need
It
to knock that
scares
thing.
the shit out of you now. Like I said, how many times I say, every time I have a hot flash, I'm like, oh my God, that's my brain cells. That's my heart. Like I can just visualize, like they're ticking away, like, blink, bye, bye. They're like neurons are diving off the diving board,
They are so
and
dangerous, and we're not
it's
taught
scary.
any of this.
We're
And
not.
someone's
We're
name who's
not.
going to come up in this podcast, Dr. Rebbecca Thurston over on the East Coast, who does a lot of research on this. So there's a study going on since the 90s, the study of women's health across the nation. It's of about 3,000 women of all different races and cultures and ethnicities. And they've been following these women since they were in their 40s, and now they're in their 70s, and they have amazing data, which we're going to be talking about in this. But one of the things that she told us during a lecture at the Menopause Society meeting last year was that they, for some of these studies, they put sensors on women. On
Hmm.
their breastbone that could pick up on the temperature fluctuations. And then they also gave a woman a button to press when she felt a hot flash or a night sweat.
Hmm.
And they were missing nearly half of them.
Hmm.
They
Yeah. And
didn't
wasn't
even
it interesting
realize
how
it.
some of them were also thought that they had flashes and then they didn't?
Yeah.
So
Hmm.
Yeah.
I thought that was
So
interesting
interesting.
too.
So we
You
can't
know,
even trust our own senses. We're having
no.
way more probably than we think we are.
Yeah.
Mm.
Yeah,
Right.
absolutely.
And it's that hypothalamus that sits right here, asking the pituitary gland to tell the ovaries, I need estrogen, because the hypothalamus is so hungry for estrogen. And then when the ovaries don't make enough estrogen, that then stimulates this catalyst of what we call, candy neurons, which are like it's a neuron. It's three neurons. It's a plexus in the hypothalamus that then triggers those hot flashes. And I think, the thing that women need to realize is that when they have a hot flash, their heart rate goes up, their blood pressure goes up, they have heart palpitations because their heart is working harder. And then that leads to a whole inflammatory cascade that ultimately damages blood vessels. It can increase your bad cholesterol. It can develop calcium in the aorta, and sets women up for heart disease, which we know is the number one killer of women. I'm like, that's why providers, even one hot flash is too many, and it's not up to you to decide if it's bad enough to warrant warrant medication.
Yep.
Yes. Weren't you nerding out on the hypothalamus earlier, Rebecca?
Yes. I was
Are you
totally
going to
nerding
tell
out
us
on
some of?
that.
Yeah.
Yeah, tell us.
Yes. Oh, I I was like, "Oh my gosh, you're speaking my language." And I usually don't like all that. So yeah, just like Christine was saying, I was there was just some really incredible lectures, and so we have that kisspeptin gene, right? And so that's actually the thing that turns on, that then triggers that hypothalamus to then start sending that pulsatile GnRH, which then tells the LH to pulsatile, and then the FSH, which it's longer acting, but there are like little pulsatiles in there. And so from that hypothalamus to the pituitary to the ovaries, just like Christine was saying. But it was so interesting that we now know where it's coming from, and it's coming from neurons, and those candy neurons, like Christine was saying, you have this, the way that they're working. And when we run out of estrogen that gives that negative feedback, then this, neurokinin B pathway gets dysregulated. And so that's when these hot flashes occur. And it's just like, I was so geeking out over all of that. I'm just like, whoa, it's just like mind blowing how the brain works like that,
Mm.
and now we finally really understand where that's coming from. So yeah, your thermoregulatory center is all messed up, and the brain doesn't understand that these changes albeit small, you're feeling them as these huge changes and these big temperature fluctuations. And then you can shiver and get cold as well. That's why some of these women perceive their cold shivers instead of hot flashes. So yeah.
Mm-hmm.
So,
So once we learned all of
Fingers are worse.
Once we learned all of this, it blew our mind that all we had been taught was that if a woman is having severe hot flashes, you can offer her some hormone therapy. Hell no.
Right.
No.
Right.
One hot flash is like having a tiny little mini stroke.
Yeah. The hyperintensities in the brain, right?
Yes. That's right. Just like, and what I say to my patients for them to understand is, those hyperintensities are equal to uncontrolled blood pressure. When someone has uncontrolled blood pressure, that's the same type of pathology that they see in the brain, and then they're just like, because they can understand uncontrolled blood pressure. They know how detrimental that is. And so that for me is what I use just to help them understand. And that can give you then that vascular dementia, right?
Struggling with mood swings, low energy, weight changes, or feeling dismissed about your hormones? You're not crazy. You're in midlife. I'm Dr. Rebbecca Hertel, board-certified osteopathic physician and certified menopause practitioner. And at Osteopathic Midlife Health, I offer personalized concierge telemedicine for women in multiple states, helping you navigate perimenopause and menopause with expert care focused on hormones, weight, sleep, libido, and more. My approach blends evidence-based medicine with a deep understanding of longevity and precision midlife health, because this phase isn't just about getting by, it's about thriving for decades to come. So visit www.osteopathicmidlifehealth.com and let's build your roadmap to lasting vitality.
And so, I think about those things
from that SWAN study. And they showed us MRIs during this talk of the brain in women who had hot flashes, and they controlled for everything else, age and sleep and everything. And you could see tiny little areas of what looked like tiny strokes. And then they showed us the exact same picture, but it was in women who lost sleep. Mm-hmm. And nothing to do with hot flashes or any other confounding factors. And they also had the same changes in their brain. And they think that women who are losing sleep and having hot flashes have double whammy on their brain. So this is such a serious thing. I think probably one of the most serious things we deal with in menopause that nobody is talking about, and we are definitely as clinicians are not taking seriously enough.
We're not asking enough about it. We're not. And like we said, those rises in blood pressure, your change in cholesterol, your breast cancer risk we talked about,
that was fascinating.
That was fascinating. Yeah. Can we touch on that a little bit?
Increases your risk of breast cancer. I mean, we know alcohol, obesity.
No one talks about that.
Because it all boils down to inflammation, right? Inflammation is the key to everything. And estrogen is anti-inflammatory. If it had one job, if I had one word to describe its job, it's anti-inflammatory. And so when we lose it, like you said, Christine, this big inflammatory cascade happens. And of course, if your body's inflamed, you're increasing your risk for any cancer, right?
Mm-hmm.
Yeah.
Yeah, it was just mind-blowing, and so when we say that, we can't use it for primary prevention, I think people need to understand how difficult it is to get something okayed for primary prevention. It's nearly impossible. But what that doesn't mean is it doesn't mean that it still doesn't help prevent things occurring or taking longer. So, it helps prevent cardiovascular disease in the long run, and the transition to metabolic syndrome in the long run, the transition to cognitive decline and things like that in the long run over time. And those vasomotor symptoms, when you're flashing all the time, it's crazy, and I was just saying I was experiencing it this last week because I had not had a cycle again for probably 2 or 3 months, and then had one. And I was wondering why that week I was flashing constantly. And, that's when you have to play with your hormones a little bit more, add a little bit more estrogen, because, the delta change from going up and going back down. But yeah, now that I'm like, that's why I was like, oh my God, my heart. Oh my gosh, my head. Oh my gosh, my brain.
I feel if everyone making these guidelines was a Gen X woman and had read all the studies, that there would be no question about using hormones as primary
Yeah.
prevention for pretty much
Yeah.
everything that women die of. So we just need to bide our time.
Yeah.
I know. I usually
keep
say
hustling.
we can't call it primary prevention, but it sure does prevent a lot of things.
Yes.
Sure does.
Yes.
Right?
Yes.
And, I was looking at a study that the Swan released of last November and just talking about the 50% increased risk of diabetes for women who have more frequent hot flashes. And so I thought that was really fascinating because I had not made I knew it was, insulin resistance and low estrogen, but I didn't make the correlation. That was something new that I learned when I was reviewing that study. And I just thought that was really, especially since I've run into a few patients here of recent who are overt diabetics and not getting treatment, who have been suffering for hot flashes for years and years. And even in that Swan study, the women had to have had at least 3 visits before they considered, and then they were looking at their diabetes. So looking at it over the long haul of, did they have 6 or 7 hot flashes a day compared to maybe only 1 or 2? And so the more hot flashes you have and the more severe, it increases your risk of diabetes. And I know so many women that are chasing not becoming a diabetic.
Yeah.
I know it's such a big problem, which also contributes to cardiac disease, right? Which is what we die of, cardiovascular disease. Yeah.
Yeah, we were just talking about that. Yeah.
What's the first thing we reach for when a woman tells us that she has hot flashes? Which treatment? HRT.
Prescription.
Estrogen is
prescription.
still the gold standard for the treatment of vasomotor symptoms.
Right.
I know. And I have some friends
that's
who
the
I
FDA
think
approval for that, right? So let's remind our listeners, that estrogen is FDA approved for, 4 things, and that being one of them. Not that we don't use it off label, for other things like many other medications. Let's put that out there. But yeah,
can I say one thing about FDA approval as well? Sorry, Rebbecca.
Yeah.
Just the FDA, I looked this up a few weeks ago, so I'm going to get the numbers wrong, but roughly FDA approval of estrogen to treat vasomotor symptoms was given in 1942.
Ooh.
And then in 1960 something, it got its next FDA approval, maybe for genitourinary syndrome and menopause. And then in 1970 something, it got its approval for prevention of bone loss. So what other area of medicine do we go by FDA approval from something from 1942? Right. I mean, come on.
Long time.
Everyone spouts this. Well, it's FDA approved for these 4 things, so I can't give it to my patient if they don't fit into these boxes.
I know.
Guys,
when they do, they won't give it.
We're using medicines in women, in patients who have breast cancer,
and then
that haven't even been studied in women who have breast cancer. And you're telling me I can't use something off-label because it wasn't approved in 1942? No. No.
It doesn't.
I don't think in our lifetime we'll get approval for all the other things that we know it is.
No.
If we're sitting around waiting for these studies, we'll all be dead, dead. Yeah.
And I think another thing for women, one of the most common things women, especially in perimenopause, have is mood changes and anxiety, and, low estrogen, low serotonin, hot flashes are related, do cause anxiety. And some of that, of course, is probably because of, poor sleep, but it's also because of the decrease in serotonin. And so, it's just another piece of the puzzle of why.
Sometimes a hot flash is an anxiety and a palpitation.
That's true.
Yeah. And if you're having tiny little strokes,
that.
How could your brain be functioning properly and making enough of these neurotransmitters,
Don't forget the strokes.
Yeah.
That's right.
Do not forget the strokes.
Little mini strokes that you're having. Maybe that's why sometimes it's hard to be fluent and find my words.
Right. And I mean, I don't think we don't want people to think that, we're being dramatic, but I
Right.
just see so many women just saying, I can gut it out. It's not too bad. Or women celebrating, I made it. And I'm like thinking to myself, well, I wonder how your brain is.
I
Like,
know. Or your
between
heart.
flashes, cognitive decline, Alzheimer's. And so I wonder how your brain is, or where, are
Hmm.
you going to have a stroke or heart failure or heart attack? And I just
Yep.
I want women to stop looking at hot flashes as this, red badge of courage, and that, they get like a medal like they just served in the military because they had hot flashes.
Well, yeah.
And and then that discourages other women, or other women want
Yeah.
hormone therapy and they feel guilty because they're not suffering. No.
But
And how many have they said that to you where they're just like, but my friends were talking and it wasn't as bad as my friends, so I just didn't say anything because it wasn't as bad
Mhm.
as they were saying. Like, why do we do that to ourselves?
And the women who very often say this to us, I made it through. I had hot flashes for like 2 or 3 years, but I got through it. I didn't have any other symptoms. And I look at their med list and they're on a statin for high cholesterol.
Yep.
They're on a blood pressure medicine for high blood pressure.
Yep.
And they're on a medicine for diabetes or
And
pre-diabetes.
probably
No,
anxiety or depression.
you didn't make it through unscathed. We just put
No.
band-aids on you instead of
Yep.
treating the underlying problem, which is not how we're taught in medicine. We're taught
That's
you
right.
treat the underlying problem. You don't put band-aids on things and cover up the cracks.
That's
So
right.
it's just a lack of knowledge overall for all of us.
Yep. And it's
And I think
interesting
that's
because
important for clinicians. Like,
yeah.
look at the people you're telling no to hormone therapy, look at their med list.
Yep.
How many meds do you have them on? And are you treating all of those things? If the
Yeah.
answer is yes, again, you shouldn't be taking care of midlife women. If you just put them on a little estradiol, a little progesterone, they probably could come off of their other meds. And interestingly enough, when we talk about hormone therapy, I had a patient text me this weekend who was just put on lisinopril a few months ago. And I started her on hormone therapy, and she's like, I was really lightheaded and dizzy. I took my blood pressure. Her blood pressure is beautiful. She's like, what do I do with this hypertensive med? I said, well, I didn't prescribe it to you. I said, but I'm not going to tell you to stop it, but I think a trial of being off of it would be
Reevaluate it. Yeah. I think you need to definitely lower it if you're getting
like primary. Tell them I
and
put you on
go.
hormone therapy.
Yes. Yes. And and let's go back kind of to the brain where we talked a little bit. I want to go back on that too, because it's not just, this is the brain, the serotonin, the norepinephrine, the candy neurons, all. So, these are all these hormones that not just affect, mood, but those affect temperature regulation as well, and how these signals, heat loss signals and temperature regulation. So there's a lot of those neurotransmitters that become affected, and in addition to your mood and libido and things like that too, but those are also involved in temperature regulation and being able to perceive how heat is being lost in your body, so these are brain things, ladies, brain chemicals, brain neurotransmitters. This is all brain. And so how it, again, going back to this, is really important that one hot flash, like Christine said, is too many. And the fact that we tell women, not us, but that it's mild to moderate hot flashes, that you have to be really suffering before.
And we would have said that, right? We would have.
Yeah, we
before
would
we
have
did all this
100%.
extra training. Yeah. Mm-hmm.
Because now if someone comes in and says they're bad, as soon as I see they check, they're even having mild hot flashes. Yep. The first thing, how are you tolerating your estrogen? Any breast tenderness, bleeding, bloating, or bitchiness? Yep. And when they say no, I'm like, we're going up. Yeah. They're like, really? I'm like, let's knock these out. I'm like, and then you can reevaluate in a few years and come down on your.
You might have to go back down, and they feel bad for like, well, it's so much better than it was. Well, yeah, but it could be better.
Yeah, you're not dying anymore. We want better than that.
Yes, exactly.
For any of our Oh, I was going to say, for any of our listeners listening to us thinking, I hate you bitches, I can't take hormones, or I don't want to take hormones,
Yeah,
and
let's
you're
talk about
scaring me, let us just be very clear. We are making a big deal of this, and we are talking about hormones because this information has been withheld from all of us. And we
Yes.
are angry about that and revved up, and we want to get the message across. To treat the underlying problem, the best medicine is hormones. But there are some women who don't want to take them or can't.
That's right.
And yes, we have other great options. We're not saying we don't. But
Right. Absolutely.
why have we never been told that hot flashes are should absolutely not be happening? We should not be allowing them. That's the point we're trying to get across.
Yeah. And what happens if they, what happens to our bodies and our health, not just our bodies, our health, when they are not controlled. How long have we all been in practice, you guys? We are veteran practitioners here, right?
Probably 90 years between
90
us.
years.
Yeah. So,
Long
and these are, it still blows our mind. Like we were just talking as we were doing even more, researching on this, preparing for our podcast. And we're just like, our mind is like blown every time I prepare for a lecture, a podcast, whatever it is. I'm just, and irritated would be the other thing, is just because there's a whole realm of my body that I don't know about as a practitioner that takes care of other women. Like, I am a woman and I take care of them. And how come I didn't know these things? It's just not okay. I get really irritated about that too.
Yeah, there is nothing like this for men. There's nothing that's been withheld from them for 20 something years that would have given them a 3 years of extra healthy life or kept them out of nursing homes for the last 10, 15, 20 years of their lives. So yeah, we're fired up. We are. Fuck it. We're fired up.
That's right. And we like to be fired up. And we know that you all like us to be fired up. So now we got the fire.
Fiery Dusty Muffins.
You said something that, I think is an important thing to tap on, which was if you can't be on hormone therapy. But there are women who can't. But what I find more and more, especially looking at all these, I'm on every Facebook group about HRT and hormones and perimenopause. And just as an aside, before I get to my point about that, is I'm amazed at all of the people who are taking their medical advice from other people that are on hormones or been in menopause. I mean, it doesn't make them experts. Please stop using them as your source of information. I'm like, it takes me a little bit because women have gotten PhDs, right, in menopause. And so they're really accurate. But stop taking your hormone advice from people on Facebook who are just people in menopause, and people find yourself a menopause expert. But I digress.
Yes. But and I think they've got some of that from just, some of even our, Hollywood
celebrities.
Stars. Yeah.
Right. That are not experts. They're just great.
No, it's a great platform and advocacy. Yes, 100%. And truly, if you listen to them, they all should be saying, make sure that you find a practitioner that can help you with these things.
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, CME, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
But what Rebbecca and I were talking about that this week, because I was getting fired up on these groups. So I was like, all right, I have to get that out of my mind. But, women think they can't be on hormone therapy based on, I don't know, maybe the Facebook groups or my aunt or mother or whatever. And I mean, there are very few red lines with menopausal experts these days. I mean, and you tell me if you guys added a little bit different. I used to talk about even, blood clots, which, I'll give someone with a history of blood clot hormone therapy, transdermal. It doesn't increase the risk of blood clots. But, I tell women now, active breast cancer in treatment or on aromatase inhibitor or tamoxifen, if they need a liver transplant, end-stage liver disease, and if they've had a recent stroke or a recent heart attack. Those are really my 4 red lines. I don't know if you guys have other additional red lines.
Well, can I let's just take the end stage liver disease.
Yeah.
Someone with end stage liver disease is dying, right? And if they sit in front of me and say my quality of life is so bad and it's all since I came off my hormone therapy and I'm dying, that is not a contraindication for me. If I give them the information that this could make their liver disease worse, which transdermal, it probably won't. I think that liver information comes from the Women's Health Initiative study with the oral estrogen. Am I going to say you can't have your hormones back? Absolutely not. So I agree with you. Very few red lines. I remember the first talk I gave on this, I had a whole slide on all the contraindications. Now I have no slide.
Yeah.
I just mention a few cases where it may not be a great idea to give someone hormones, but that slide's gone because the more I've done this and the more I've learned, I've realized that's complete bullshit. It's all based on the Women's Health Initiative, oral combined equine estrogen and oral medroxyprogesterone acetate, which was almost inflammatory and undid all the good that the estrogen was doing. So no, I agree. Very few contraindications.
I agree with you too.
And then women just go on suffering because they believe that it is they can't be on them. Yeah, I think that's a really good point because I don't know if you've all noticed lately, what I've been getting are 65 to 70-year-olds knocking down my door, and they are so healthy and they're still having hot flashes and they're like, I want hormone therapy. And they come to me, they must hear me in places because they're like, I've had my coronary calcium score, my cholesterol's really good.
There you go.
I
love it.
Listening, please, can I go on hormone therapy? And, it's like this whole new surge of people that I'm like, and I tell women, I don't think it's ever too late. It is.
Well, especially if they still have hot flashes, right? They still have hot flashes. They're probably all osteopenic, if not pretty darn close. So right there, if you want to be the goody two shoes, there's your FDA approved reasons, right?
But we still hear big names in menopause saying, if you're within 10 years of your last period, you can start on hormones. We have to stop saying that to women. That is old information. It's not accurate. It's all based on oral meds that we don't tend to use that much anymore. And we're not giving women accurate information when we say you can only start within the first 10 years. I feel like we've weaponized that window of opportunity that we learned from certain studies where you get massive cardiovascular benefits. In observational studies, you can see a 30 to 50% decrease in cardiovascular disease if you start within 10 years of your last period. You don't see that after the 10 years. But somehow we've weaponized that piece of information and turned it into you can't take hormones after 10 years. That's not what it said.
No.
And the studies didn't say that it increased the risk.
No.
It's no benefit. Like it doesn't increase
their 70s. It does. If you give them oral medroxyprogesterone acetate and combined equine estrogen, amazing. People get clots when you give them two medicines that cause clots. Shocking. Absolutely shocking. I just don't get where the logic has gone. Where is the fucking logic gone when we talk about women?
It's gone. They're just so scared. So
I'm so fired up, girls. I can feel the hot flash coming on.
I can feel it coming through.
We'll have to do a part 2 where we talk about the non-hormonals and what the Menopause Society says, not the Menopause Society, but what the evidence says about non-hormonals and lifestyle, all the supplements that everybody's doing. I think that would be a really good part 2.
Yeah, I think that's a really good one. And because I think it's its own podcast all in one. And can I just quick go through as we're wrapping up here, just kind of a little bit of the list of the consequences of not treating. We talked a little bit about the decreased quality of life, sleep disturbances, cardiometabolic changes, coronary heart disease, fracture risk, but healthcare costs as well, right? So healthcare costs increase because women are, they're not sleeping or they're depressed. And so they're on medications, they're not going to work. And then the workplace also, 10 to 20% of women leave or put their career on hold. So that goes toward, loss of income, their loss of leadership opportunities, and then employer costs go up. So, I think the last statistic, I know, Kristen, you have a good one, 2 billion in missed work days, for women. So this is not just a me problem. It's not just a women problem. This is an economic issue as well. So we need to think about that. We are 51% of the population. So, okay.
Perfect. Life's too short to have a hot flash.
Yes, life's too short to have a hot flash. Peace out. We're done.
Yeah. We hope we've got you all fired up, our dear listeners. Go do some research on this yourself. Don't just take our word for it. Look up the study of women's health across the nation, and follow us on our Instagram page at the Dusty Muffins. And we'll look forward to seeing you at our next episode.